Good afternoon, dear doctors. You all can hear me? Yeah, okay. A warm welcome once again to another insightful webinar conducted by Homeopathy Middle East. Today we learn about interpretation of chest X-ray and its application in clinical practice by a renowned physician, Professor Dr. Ajayan. With this, I will hand over the platform to Dr. Santosh, who's the moderator for today. He is a well-known figure in Middle East and does not need any special introduction. But before I hand over to Dr. Santosh, I would like to invite Dr. Srilekha to say a few words about Dr. Sulekha. Dr. Srilekha, I think you can just take over and you can talk about her.
Good afternoon, all doctors. It was a shocking news for all of us that our colleague and one of our senior most homeopathic practitioner in Dubai departed us on last Sunday.
Sorry, Dr. Srilekha, sorry to interrupt you. There's a lot of static coming. We can't hear you clearly. Can you, your mic, is it moving or something? Can you please?
No, doctor. Let me check once again.
Yeah, just check.
It's okay now?
Yeah,
Okay.
try.
It was a shocking news for all of us that our colleague and one of the senior most homeopath of Dubai, Dr. Sulekha, departed us on last Saturday. Dr. Sulekha Vivi was practicing in Dubai since 2003. She started her practice in Koya's Clinic, Deira, and then shifted to Jamila Polyclinic in Deira, Dubai. She was very sincere and a duty-bounded homeopathy practitioner with her soft-spoken and warm nature. She was an understanding wife and a great mother to her two lovely daughters and a good friend to all of us. Yesterday, some of the doctors visited Dr. Sulekha's house and met her husband and the children. And for her loss is really a loss to our homeopathy fraternity in UAE also. May her soul rest in peace, and may God give enough strength to her husband and children to overcome this moment. Thank you.
Thank you, Dr. Srilekha. With this, I hand over the platform to Dr. Santosh.
No, we will have a 1 minute.
Let's have a 1 minute silence
before we
start.
Okay.
Yeah.
Silent prayer.
Yeah, 1 minute
Yes.
of silence before we start, please. Yeah, we can start now.
Doctor.
Dr.
Santosh, Dr. Santosh, you can start now. You can,
Okay.
with the introduction of Dr. Ajay.
Yeah. Thank you, Dr. Ritu, for the informative speech, and Dr. Srilekha for the condolence message. Good afternoon, friends. As part of our vision in Middle East homeopathy, we give importance to science. understanding everything scientifically, even understanding our materia medica in scientific way is extremely important for all of us, for upgrading our system of medicine throughout the world, especially in this region. Today, we are having a speaker who is going to enlighten us with the interpretation of chest X-ray in our daily practice and connecting that one with our materia medica. Radiology, including X-ray, this CT scan, MRI, we all should have thorough knowledge in the understanding and interpreting this one with our science. In the future, we will have more classes with eminent speakers. And today, it gives me immense pleasure to introduce Professor Dr. T. Ajayan, who is closely associated with me since our college days and who is serving as the head Department of Practice of Medicine in Sharada Krishna Homeopathic Medical College, who is a great academician who teaches students, enlighten homeopathic doctors throughout Kerala and India for the last 20 years. He is a great clinician who is also working as the Deputy Medical Superintendent in Sharada Krishna Homeopathic Medical College Hospital and who has been awarded with the Best Doctor Award organized by Institution of Homeopaths Kerala in the year 2020. Moreover, he is a great researcher who is doing research in homeopathic system of medicine in the Sharada Krishna Homeopathic Medical College itself. So dear friends, we warm welcome Professor Dr. T. Ajayan for our platform. Please, Dr. Ajayan, this platform is yours now. Please join. Thank you. Dr. Ajayan.
Where is Dr. Ajayan? He's there. Dr. Ajayan, are you there? Dr. Santosh, you are mute.
Yes, what happened? Dr. Ajayan was there?
I can't see him. Can you just call and check with him, doctor?
Yeah, I will call.
Dr. Ajayan is there. To just unmute, he has to unmute himself.
Dr. Ajayan, can you please unmute yourself?
Okay, madam.
Dr.
Very
Ajayan.
sorry. Very sorry.
Yes,
Certain
no
technical issue
problem.
is there. Therefore, difficulties we are facing. Please, sir, can you start it, sir? And are you able to start, please?
Yes, please.
Yeah,
You want
Okay.
to
Then audio is clear, sir. Audio is clear.
Yeah,
Yes.
now it's clear, doctor. We have
Okay,
already
okay.
started. Introduce yourself. You can start.
Okay. Okay, thank you. Good evening to all. Respected dignitaries of this program. First of all, let me express my sincere thanks to the organizers that give me an opportunity to present a topic related to the basic of the chest X-rays. And today's our topic is an interpretation of chest X-rays. Then before that, I pay my humble acknowledgement to Dr. Santosh sir. He is my colleague and as well as one of my mentors. Today's our topic is an basics of X-rays, the interpretation of chest X-rays. I hope that almost all the doctors are aware about the basics of the chest X-ray. Then other few are even this time is not aware about the basic. Anyway, those who are in they thoroughly understand the basics of the X-ray, then supposed to be this then a refresh course, the refresh that your knowledge. Then suppose those who are not aware about the basic, then maybe this session helpful to understand the basic of X-rays. Then in disciplinary, in the disciplines of radiology, the imaging has assumed an important role in the initial diagnosis, then as well as the subsequent management of the patient by providing the cross-sectional imaging of human internal organs. Is and demonstrating the pathological lesion within them. Then and also in providing the treatment to the patient by using the different modalities. Then actually this X-rays in contemporary science will help for the diagnosis. Then we are all homeopaths. We are all know our aim is the first one is the diagnosis of the disease, and second one is the diagnosis of an individual. Then our diagnosis and as well as our individual diagnosis is based on we are collecting our subjective level symptom and the objective level symptom from the patient. If the subjective level symptom is there, we are able to diagnose the case, and as well as we are right way, we are approach the case for the individual diagnosis. That means the diagnosis of a medicine, we are reached the right way, we are able to reach the right medicine. At the same time, the objective level symptom, everybody know we are collected into the knowledge of the physician, and also then their data we are collected from the bystander. We are collecting the data from the bystander or the physician with the ideas we are collected from the patient, then again we are interpreted. Therefore, the quality of the interpretation is sometimes is dependent upon our knowledge. Therefore, anyway, in contemporary science, this investigation is very important. Before the 20 or 25 years back, maybe that X-rays, these traditional X-rays we are used for is one of the special investigations before 25 or 25 years back. But at the same time, the chest X-rays, especially chest X-rays, is used for as a part of the investigation is one of the routine investigation. This chest X-rays is helpful. Not only is helpful for the diagnosis of the respiratory diseases, not only is helpful for the diagnosis of cardiovascular diseases. In addition to this, some other diseases related findings we are seen in our chest X-rays. For example, suppose the distant organ, a metastasis is there, their evidence we are seen in our chest X-ray. Then the simple chest X-ray is helpful to work out certain musculoskeletal disorders. For example, the cervical rape, then suppose the degenerative changes of our cervical vertebrae, then etc. Then suppose the same chest X-rays, again we are helpful to work out the certain endocrine dysfunction, etc. Therefore, the chest X-rays is considered as a basic of all the traditional X-rays. Therefore, the basic, those who are a thorough knowledge about the basics of the chest X-rays, we are able to read all other traditional X-rays. Then just to please wait, then I just share my PowerPoint, then you are start the topic. Then only the allotted time is the 2 hours. I try my best level to complete the basic within these 2 hours. Just please wait. Sir, PowerPoint is visible?
Yes, sir, it's visible.
Oh,
You can do
Yes, yes.
full screen. So you can,
Okay.
yeah,
Okay.
now it's
Okay.
fine. Now it's fine.
Okay. Okay. Yes. Then why it is relevant? Because it is a very simple, effective, non-invasive, non-invasively and painlessly help to diagnose the disease and monitor the therapy. It is important today. Then because nowadays why this type of the classes are conducted by the different organization, not the reason, only one reason is your answer is the COVID. Therefore, in X-rays, the why it is an important in this particular disease, the COVID. Nowadays, then suppose that 10 patient or 15 or 50 patient is arrived in our clinic, out of this, even the 5% of cases is related to the post-COVID stage. Therefore, it is relevant today. Then population, affordability, and availability. Then chest X-rays and CT is more important. The health in our COVID has more reliability than RT-PCR tests. Then now the majority of cases and RT-PCR negative in post-COVID state, almost all the cases RT-PCR is negative. But we are advising CT scan of the chest, maybe the evidence of the previously this person is exposed to the COVID because the degree of involvement were shown by the radiograph. Then for that nowadays we are use the CT scan. Therefore, these are the different modalities, the different radiological modalities, the chest X-rays, the traditional X-rays, then ultrasonography, then CT, MRI, etc. etc. All these things they are divided into. That means the principle of imaging modalities are used today are the first one is using ionizing radiation like our traditional X-rays or the gamma rays, then fluoroscopy, then contrast studies using various contrast agent, mammography, then CT, different CTs, computed tomography, then radionuclide scanning, then other non-ionizing methods are also there in radiology. This can include ultrasonography, then Doppler imaging, then magnetic resonance imaging, MRI, etc. Then ancestral modes of investigation. This in our master Samuel Kahneman is mentioned about the obstacle to cure, and the real obstacle can be found within the help of investigation. All these things are everybody know. The investigate our exciting cause, our fundamental and obstacle to cure. Then look this X-ray. What is the finding? Then suppose we have not a thorough knowledge about X-rays. Just we are in our knowledge, we are expected in both sides the same color. Then but in this X-ray, there is an actually one half of the right side is that is the white color is increased. We are compared it to opposite side. Therefore, that time we are thinking about as a pathology. Then this but the same time this particular X-ray, the question is where arising. Then almost all the areas the same color, same distribution is there. Okay, then why in our homeopathy is very relevant? For example, in very beginning I say then we are used for any investigation or physical examination or the registry of presenting complaints. All the part of the case taking we are used for the multi-purpose. Therefore, I say always I say the homeopaths need the double brain. One is the materialistic, another one is the immaterial. That means then this time I remember the words of the H.R. Robert. I already convey with you the aim of the physician. Then all the part of the case taking they are used for the multi-purpose. The first one is the diagnosis, and second one is its help for the individual diagnosis, the medicine selection. For example, then suppose the right side 3 lobe is there. The right side, that not only this particular medicine, but the more action is an upper lobe is a chelidonium. Suppose a deaf patient, we are not able to collect the subjective level symptom. Only the X-ray is there. Maybe then with the help of the evidence, we are able to select a homeopathy medicine. Then, for example, right middle lobe is an affection is there, medullarum and sanguinaria. Likewise, then right lower lobe, three important medicine, iodine, caliodate, calicarb. But at the base, there is a phosphorus. Then lateral side is a lycopodium, chelidonium. In the same time, the left side had only two lobes. Then anti-sulfatum auratum is a very wonderful medicine, is an acting on the left upper lobe. Is a left upper lobe. Then lattice is sanguinaria, opium, camphor, then oxalic acid. These are the medicines are major. They're focusing their action on the left lower lobes. Then suppose with the focal and localized. Then in pneumonia, maybe the lesion is there. The focal and localized, the segmental pneumonia. Then important drug, the first stage of all inflammatory affection is an ferrum force. Then the congestion of the lung. Then lycopus is a wonderful medicine, is used for cough with hemoptysis. The bleeding is small but frequent. Then localized at base, only one medicine is an oxalic acid. The left lung, painful, dyspnea, short, jerky, inspiration. Then already I convey with you the passive of upper lobe of the left. There is this particular area is the main action. Those drugs, antimonium, sulfatum, auratum. It's a congestion of upper lobe of the left lung. You know, everybody know then our pneumonia is 4 different stages. The stage of congestion, red hepatization, gray hepatization, and resolution. Suppose in congestion, the left upper lobe, then one of the drug is an indicated antimonium, sulfatum, auratum. Then, like this, the number of medicine, the number of rubric in our different repertories, then majority of these rubric I have collected from my favorite. One of the repertory is nerve repertory. The advantage of the nerve repertory is a Puritan type of repertory. Therefore, all the symptoms are, the recorded symptoms are qualified symptoms. There is a based on the hearing gating symptom. Then hearing gating symptom, the knowledge of the hearing gating symptom means then proving, reproving, verification, and re-verification is there. Then only that group of medicines are considered in that nerve repertory. These are the medicine for the left from apex to base, the lycopodium. Then I come to the base. Why we are studying the imaging technology, then we are used not only for the diagnosis, then same time we are used the thorough understanding may be helpful for the selection of the right homeopathy medicine. Then as I come to the base, the radiology is a medical specialty that uses imaging to diagnose scene within the body. Then just you look at this picture, this is the tree, and this the image is there. The like that, then wherever we are exposure, just X-ray exposure is there, that image we are collected and then again we are interpreted. We are looking this image and we are find out, we are worked out. This is the branch of the tree. This is the branch of the tree. Like that, we are interpreted. This is the area of hilar lymph node. This is the area of hemi diaphragm. This is the area of postophrenic angle. This is the area of cardiophrenic angle. Like that. Then by looking this image, we are understand the exact the tree, the light. Then radiology is an indispensable part of the clinical medicine. But at the same time, as a clinician, those who are entering in clinical practice is critical for entire years, clinical years, and for a physician.
Dr. Ritu, Dr.
Yeah,
Vanida.
Is it audible?
You can't
Is it
hear.
audible?
No.
Yeah, yes.
Yeah,
Now
now
it's
it's okay,
audible?
doctor. Now it's
Now
okay.
it's audible.
Okay. Then here is a very heavy rain. Therefore, electricity is interrupted. Therefore, just this is a reason the technical issues are arising again and again arising. Please Okay. Okay, shall I continue?
Yes, yes, doctor.
Yes.
Yes. Then variety of the chest imaging or chest X-rays we are already conveyed to you. These are everybody know all these things. Then broadly divided into ionizing and non-ionizing. Then objective of the chest X-rays, then identify the normal cardiothoracic anatomical structures. Mainly we are focusing the lung pathologies and cardiovascular pathologies. Mainly we are focusing out of these two, mainly we are focusing the lung pathologies. Lung pathologies, especially atelectasis, consolidation, pneumothorax, rural diseases. Then in cardiovascular disease, the pericardial effusion, cardiomegaly, the different chamber enlargement, then hyperinflation include bronchiectasis, then emphysema, etc. The correlate the physical sign and symptom of cardiopulmonary disease with the chest radiographic finding. Yes, the normally chest X-rays we are taking. The view is the PA view. Then in traditional X-rays, all other X-rays we are taken is an AP view plus some other special views. But the chest X-rays are where commonly taken the PA view. What is its advantages? This picture may be helpful for you. It's very important. The PA view means an X-ray beam pass from behind the posterior side and the film plate is we are placed over the anteriorly. It is the PA view. The film plate is we are placed anteriorly and the X-ray beam pass from behind, just opposite side, that is posterior side. Okay, then one formula is there. Distance is directly proportional to magnification. Distance is directly proportional to magnification. Suppose that distance is less, that is a magnification also less. Then you know it's a harmful to human body. Then X-rays are harmful to human body. Therefore, then a single exposure, through the single exposure, we get the maximum data. Then here the chest X-rays, the maximum data means we are collecting the data related to respiratory system and the cardiovascular system and the musculoskeletal, certain areas of musculoskeletal system. Then here then very important structure is the heart. The heart is normally we are seen in the middle mediastinum anteriorly. Therefore, the distance in between the film plate and the heart is less. Therefore, the magnification is less. Therefore, right way we are able to work out our heart shadow. That is an advantage of PA view. Then suppose we are advised AP view, what happened? The film plate is we are placed here. That time the heart, from the film plate, the distance in between the heart and the film plate is more. Therefore, what happened? The magnification is increased. Therefore, blurring the field of the heart. That is the disadvantage. The advantage of PA view, the maximum data we are collected related to cardiovascular system, mainly heart. Then chest X-rays, it need the sun percentage resolution. That is first part. The sun percentage resolution means a good contrast, and second part is fine details. That means in a particular X-ray, a good contrast is there, we get fine details. The good contrast means then is the proper mixing of black and white color. The proper mixing of black and white color. Then proper mixing of black and white color is there, definitely we get fine details. Then chest X-ray while reading, then 6 point is to listen. First one is the good contrast, and second one is film focal distance, FFD. The quality of the chest X-ray is determined by these 6 points. The first one is good contrast. Good contrast means proper mixing of black and white color. We have discussed one by one. And second one is FFD, film focal distance. And third point, we are concentrate the geographical details. That means the size of the focal spot, the X-ray beam post focal spot, the size is small, we get good details. If it is large, very less details. Then fourth point, while exposure, during the time of exposure, imperfect immobilization. Then otherwise, then film is the shaking. That is, the body is shake. The body shake at that time we not get the correct image. Then fifth point, the gauge of the film. The gauge of the film that is determined by the quality of the film. Then sixth point, the correct centering and accurate positioning. These are the 6 points to be listened for the correct or right image. And discuss one by one. Good contrast. Good contrast means the proper mixing of black and white color. In our chest X-rays, the hundreds of structures are there. Again, the hundreds of pathological evidence are there. All these pathological evidence and pathological findings and the normal structures, we are understand through only two colors is the black and white color. Therefore, the thorough understanding only helpful to differentiating two structures, the two normal structures, and again, you are able to differentiating two abnormal pathological conditions. Therefore, the good contrast is there. The good contrast, the proper mixing of black and white color is there. We get the fine details. So, so many factors are then depending. Then one is the photography factors. Then second one is then voltage penetration. Then average voltage penetration time within the cardiac cycle within 0.8 second. The proper time, that is the 0.8 second. Voltage, the voltage is not right, around 360 is less, then white contrast is increased. Then control of scattering and the processing of development. But nowadays, then there is no any processing and development. Therefore, almost the picture is very clear. But in traditional X-rays, there is a processing and development is there. In digital X-rays, there is no any processing. Therefore, the quality is very high. But in traditional X-rays, there is the processing and development is there. The for processing, we are used the different the chemicals. Suppose the concentration of the chemicals is affecting the quality of the film. If the quality of the film is affected, that means the black and white color is affecting. We are not able to differentiate in two normal structures from and is the different pathological condition. Then the lights. So for example, all these are blacks, but we are carefully listen. We are differentiating. The color is the two different color of black is different. Two different colors. Otherwise, we are similar. All are black in color. Then here these all are white shadows. But the concentrating these white shadows, two different colors, we are able to visible in all these shades. Otherwise, we are called it as all these are white. Then suppose we are just to reach in our test states, then for a suppose a for a cloth, then same color, yellow color is we are looking, the different yellow colors are there. Like that, we are looking our X-rays. We are able to thoroughly, we are work out the X-rays. We are able to differentiate these different white color and different black color. Okay. Then film focal distance. An average distance is 150 to 180 centimeter. In between this, that means an average 5 to 6 feet, which will give a good CTR ratio. CTR means cardiothoracic ratio. The right cardiothoracic ratio, we are helpful to work out whether the heart chamber is enlarged or not. For that, then film focal distance is very important. Then geographical details we are already discussed. If it is small, good details. If it is large, less details. Then imperfect immobilization. Imperfect immobilization, when the movement is present, the blur in the field will be seen. That is, unshaked film object is essential. Then gauge of the film. Then already in product companies are two kind of the film is there. One is then very thick film, another one is very thin film. During that time, then camera with we are focusing, then very thin film, we get the right image. Like that here, the film is the very thin film we are used for the X-rays, we get the fine details, good details. The correct centering and accurate positioning. The correct centering and accurate positioning, we are understand through, we are calculating the distance in between the acromioclavicular joint to sternoclavicular joints. In our X-rays in both sides, we are visible two joints. One is acromioclavicular joint and the sternoclavicular joint. In both sides, the distance are equal. Here says the correct centering. I'll show you. Then, if the right way we are taking an X-ray, this X-ray shows these 10 qualities. That is, we are called it as ideal qualities. These ideal qualities are there, then around 80% to 90%, 80 to 90%, we get the fine details. Therefore, when we are reached while reading, while starting the X-ray reading, at least we are concentrate these 10 points. The first point, it should be taken in full inspiration. How you identify it will taken full inspiration? Just please work out that 10 the posterior part of rib is exposed in X-ray. It indicates it will be taken in full inspiration. 10 the posterior part of the rib. Then second point, the scapular clean of the lung field. I'll show you through in X-rays. I'll rectify it. They are just to convey with you. Then third point, the apex that should be projected above the clavicle. That means while reading a base an important role, especially we are worked out the different infectious diseases like tuberculosis, and second one is then our tumors, and bronchogenic tumors is the most commonly affecting the apex of the lung. Then fourth point, in our X-rays, the fine vascular markings, the bronchovascular markings are there, is present or not. Then fifth point, symmetrical projection of both the lung fields. And the sixth one, well-defined cardiac outline. The well-defined cardiac outline is there. We are able to study the different chambers of our heart. The shadow of the spine seen faintly through the heart shadow in traditional X-rays. The shadow of the spine seen faintly through the heart shadow, but not see the IVD space. That point is please important one. Please note it. They never see the IVD spaces, but we are see the heart shadow through the heart shadow. We are able to see the spine, but never see the IVD space. Then the both postophrenic angle must be included. The postophrenic and the cardiophrenic angles, both CP angles, postophrenic and cardiophrenic. Then part of the neck should be included. Then lateral chest wall should be included. These are the 10 qualities. Then it should be in full inspiration, is denoted by then presence of rib, the posterior part of rib up to 10. The first quality, I repeat, the 10 qualities. And second quality is the scapular margins away from the lung field. Then for that just while reaching the room, then the technician advised the patient just to hold a bar is there in front of the film plate, that just to hold that one, that time, our medial part of the scapula away from the lung field. That time the scapula is clear. The clear parenchyma of the lung field we are visible. That is scapular clean of the lung field. Then third point, then apex above the clavicle. Then apex above the clavicle. Is an area of the Pangos tumor, then primary complex, etc. Then fourth point, the fine vascular marking. The like our taproot and fibrous root. A particular plant is like this, a taproot and some fibrous roots are there. Like that structures is an area of the hilum. The fourth intercostal space is the area of the hilum. Then from the primary bronchus, then the branches are there, vascular markings are there. It is fine vascular markings. The bronchovascular markings are increased, the classical indication of chronic bronchitis. Then symmetrical projection of both lung fields. The equal rights. That means the distance from this one is sternoclavicular joint and here the acromioclavicular joint. In both sides, the distance are equal is a symmetrical projection. Then well-defined cardiac outline. Then because the well-defined cardiac outline, we are able to work out the different chambers, right and left side. We are discussed later. Then seventh point, the shadow of the spine through the cardiac shadow. Through the cardiac shadow, they never see the intervertebral disc space, but faintly see the spinous process. The spinous process we are always seen like this. Then a flame-shaped structures we are visible in the mid part of the chest X-ray is the spine. The candle flame-like appearance. Candle flame-like appearance. Then this is the area of the costophrenic angle. Costo means is the rib coincide with the diaphragm. Is an angle is there is a costophrenic angle. The costophrenic angle is significant in case of pleural effusion. The effusion is there, the blunting of this costophrenic angle. Then again, the more and more fluid is collected, even the cardiophrenic angle also blunting. Is the cardiophrenic. Heart coincide with the diaphragm. The right and left. Then here the left cardiophrenic angle is a left costophrenic angle. Then part of the neck should be included. Then here we are visible a translucent area. A translucent means a black area is indicated the trachea, the part of the neck. Then again, the cervical rib, the C7, erase our cervical rib. The cervical rib, tracheal marking, cervical lymph node, etc. is visible in if the neck is included, we are visible all these structures. Then lateral chest wall is included. But in this X-ray, the right lateral chest wall is not included because we are not able to work out the related parenchyma, related abnormalities. We are not work out. There is a disadvantage. These are the 10 qualities. Then we are normal layout. The view is an PA view. Then well centralization. Well centralization means the distance we are calculated the right and left side, acromioclavicular joint to sternoclavicular joints. The distance are equal is well centralized. Is an spinous process. These are denoted the spinous process. This one is an sternoclavicular joint. Then another part is then identify the sex. The sex we are identified the presence of the mammary shadow. Then in pendulous breast and always the mammary shadow we are seeing the lateral outside of the lateral chest wall. Then diaphragm, right and left diaphragm is there, is the right hemi diaphragm. The right hemi diaphragm is the left hemi diaphragm. The right and we are comparing right and left. Right hemi diaphragm is slightly projected. There are two reasons. One of the reason is the heart is we are situated on the left side. Therefore, due to the gravity, the slightly downward or left hemi diaphragm. Then another one is the presence of liver just below the in right side, just below the diaphragm, we are seeing the liver. Then rib cage and the clavicle are normally well visualized. Then cardiac shadow. In cardiac shadow, just we are work out. Just a minute. Yes. Then right side and left side. Then suppose in cardiac shunt is an aortic knuckle. Then just below that is an area of pulmonary trunk. Then just below that the area of the left atrium. Then remaining area of the left ventricle. There are in left side the four main dilatations are there. The first one is the aorta, and second one is the pulmonary trunk, and third one is the left atrium, and the fourth one is the left ventricle. Suppose in between the pulmonary trunk and the left atrium, another dilatation is there, maybe is an indication of left branch of pulmonary artery. Therefore, the commonly then fourth dilatation is there. Suppose in physiological condition, maybe the enlargement of pulmonary trunk and as well as the left branch of pulmonary artery, then a dilatation in between the pulmonary trunk and the left atrium is an indication of left branch of pulmonary artery. But in the same time, right side, then area of just opposite to the left ventricle, then almost area is occupied by right atrium, not right ventricle, right atrium. That just above that a dilatation is there is an indication of the ascending aorta. The ascending aorta is a rise from right ventricle. Is an ascending aorta, then again is an continues to arch of aorta, that is an aortic knuckle. Okay. Therefore, in right side, two dilatations, mainly two dilatations. Respective one is the right atrium and the ascending part of the aorta. In left side, then four dilatation, main dilatations are aorta, pulmonary trunk, left atrium, and left ventricle. In between that, pulmonary trunk and the left atrium, left branch of the pulmonary artery. Okay. Then lung shadow normally translucent. The normally translucent means translucency means the black color. The dark in color, look for any opaque shadow or hypertranslucency. Hypertranslucency means more black in color. Then for example, in our alveoli, suppose more air is collected, then we are seeing more black in color, more dark in color. What are the condition? More black, more air is inside the alveoli. The best example is emphysema. It's an under COPD. In COPD, the hypertranslucency. Then vascular markings due to branches of pulmonary artery accompanied by corresponding branch of the bronchus. Then another very important structure we are identifying hilar density. Hilar node, actually we are work out in our X-rays in fourth intercostal space. Then last, we are work out the lymphatic interstitium, alveoli, and pleural cast. A very low densities and are difficult to identify. Therefore, lymphatic and interstitium and alveoli, we are not able to work out in traditional X-rays. And finally, conclusion. As a good X-ray is and shows all these qualities. Then look, then a good X-rays, then always we are read from above downwards. Above downwards or center to periphery. The above downwards or center to periphery. We are already discussed the 10 points. I discussed these 10 points. Then we are check out what are the qualities that present this X-ray. This X-ray actually test X-ray view of a female patient because the mammary shadow is there. Then the structures we are seeing above downwards, the bony structures in central part, the look, the flame-like appearance is an indication of the spinous process. The spine of the cervical vertebrae, then thoracic vertebrae, then structures, then anterior part of rib and the posterior part of rib. Then listen, then very important one, the majority of the doctors misinterpret is the anterior part of the rib. Actually, this one is not anterior part of the rib. This one is the posterior part of the rib. The anterior part of the rib always laterally upwards. Where carefully looking, we are able to work out the anterior part of the rib. Then laterally upwards. Then suppose this one is the laterally upwards. Laterally upwards, anterior part of rib. laterally downwards is the posterior part of rib. Therefore, a doubt arising in between the doctors. Why in PA film, the anterior part of rib is not clear, the posterior part of the rib is clear. Why? Because the distance is more in the posterior part of rib than the anterior part of rib. The reason is the two things. One is the calcium deposition is more in the posterior part of rib. That during the time of exposure of X-ray, X-ray be more X-rays absorb the calcium. Therefore, the posterior part of the rib is very clear than the anterior part of the rib. The calcium deposition is very high in posterior part of rib. Therefore, absorption rate of the calcium is absorbed more amount of X-rays. Therefore, very clearly we are visible posterior part of the rib. Then here one of the quality is, the first quality is 10 the rib is exposed. Yes. Then above the clavicle, distant clavicle, above the clavicle we are count 2 posterior part of rib, 1, 2, 3, 1, 2, 3, 4, 5, 6, 7, 8, almost 9 rib is exposed. This is a good quality. The first quality is maintained. And second quality, then lateral, then scapular margin away from the lung field. And here the scapular margin is not overlapping. Then the both side cardiophrenic angle and the costophrenic angle is there. This is the costophrenic angle and this one is the cardiophrenic angle is visible. Then fine bronchovascular marking is visible. Then well-defined cardiac shield, another qualities are maintained. Then Hemi diaphragm is present. Then lateral chest wall is included. Then in this X-ray, that is an acromioclavicular joint. This one is an left side acromioclavicular joint. The distance between acromioclavicular joint to sternoclavicular joint in right side and left side is equal. Therefore, well symmetry is maintained. These are the 10 qualities of a good X-ray. Then what are the standard view? Then commonly, then traditional X-rays, we are used the PA view. Then suppose the even today the doctors are advised the lateral view. Then anteroposterior view, we are mainly used for the study of the vertebrae, especially. And then suppose then fall from height, the fall from a tree, then weight and over the thoracic vertebrae, and then maybe we are able to advise a B view. Then because the distance is less, then thoracic vertebrae and film plate, the distance is less. Therefore, the correct image of the vertebrae or thoracic vertebrae is very clear in our image. Therefore, we are used the AP view. Then other special views are lordotic view, inspiration and expiration view, reverse reserve lordotic view, then supine view, lateral decubitus view. But all these the special views nowadays we are not used. But olden days these additional views, these special views are used, but today is not used. The reason is that other sophisticated imaging technology is there. Then through the routine investigation, that means the PA view, then suppose a finding is there or a doubt we are erasing, we are directly advised the CT and other imaging technology. Therefore, we are not dependent these special views nowadays. Then importance of the different views, the PA view we are already discussed is a normal PA view. Then structures are in left side. The listen a translucent area is visible in the middle is an indication of the bronchus. Then middle a candle flame line structure is an indication of the spine. Then above the clavicle we are seeing a well-defined area, translucent area is visible is an apex. Is an area of an apex. Just a minute. One of the bad quality of this X-ray is the medial border of the scapula is overlapped the lung field. Look here, this is a medial border of the scapula. If that overlap the lung field, if the defect is Then here a pathology is there. In this area, a pathology is there. We are not able to work out. That is the disadvantage of this X-ray. That one of the bad quality of this particular X-ray. Then here this side, a minimal area is an overlapping. Minimal area is overlapping. Then one of the bad quality of this X-ray. Then here, the aortic knuckle is very clear. This is the area of the pulmonary artery. This is an area of the left atrium. This is an area of the left ventricle. This is the area of the right atrium, not right ventricle. Now listen, is that very clearly we are visible ascending aorta. Is that ascending aorta? A dilatation we are seeing above the right atrium is an indication of ascending aorta. Aorta rise from left ventricle. The continuation of arch of aorta, then is descent downwards is a descending aorta. This one is the descending aorta. You carefully listen. This area white color and this area white color, both are white, but difference is there. Density variation is there. Sorry. The lateral view. Just you have compared PA view and the AP view. Very sorry. Is a PA view, is an AP view. Then another view is a lordotic view. The lordotic view may be helpful to work out the apex. Then because then X-ray beam pass from this area and film plate is placed here. Therefore, we are right way we are exposed the upper part of the lung field. That is an apex of the lung is very clear. Otherwise, an apex of lung overlapping then a shadow of the clavicle is an advantage of lordotic view. Nowadays, the doctors are not advised these views. We are directly advised other imaging technologies. The lateral decubitus view advantage is the look the picture, then is mainly essential for to work out the mobilization of fluid. Then suppose the supine posture normally due to the gravity fluid is accumulated in the lower part, lower segment. Suppose this patient is lying on right lateral decubitus or left lateral decubitus. What happened? This fluid is mobilized to dependent part. That time, then very at first in supine posture, the fluid is collected in this area. This fluid is mobilized to lateral part. That time very clearly visible the parenchyma is visible. In this manner, we are able to work out the fluid collection. Then paired inspiratory and expiratory view, nowadays not applicable. Then oblique view is there. Then before the starting the conditions, just you aware about the surface anatomy. The surface anatomy anteriorly, most of the area is occupied by right upper lobe. There is an almost we are concentrate first to fourth rib. First to fourth rib is an area of RUL, right upper lobe. Anteriorly, remaining area, the fourth to sixth rib. Fourth to sixth rib occupied by right middle lobe. This is an area of right middle lobe. Then anteriorly we are not visible the right lower lobe. Then lobe division by the oblique and horizontal fissures. But in left side, almost area anteriorly visible by left upper lobe. The only minimal area is visible the left lower lobe. Okay, in surface anatomy. Then posteriorly, the majority of area is occupied by both left lower lobe and right lower lobe. Look, then area from the thoracic E2 to E4. This area for left and right upper lobe. T4 to T9, almost area is occupied by left lower lobe and left right lower lobe. Majority of area is occupied by. Then lateral, then oblique fissure from the second, an imaginary line you are drawn from second thoracic spine towards this sister rib, towards the sister rib. The look, this is a picture from the second thoracic spine towards the sister rib, equally divided into two parts. The lower segment, almost area is occupied by right lower lobe. It is represent oblique fissure. Another horizontal fissure, an imaginary line from a horizontal line drawn from fourth rib towards this oblique line. From the fourth rib towards this oblique line, then upper segment divided into two. Upper part is right upper lobe and lower portion is right middle lobe. Then why the doctors are, we are all auscultate the lateral chest wall? Reason is simultaneously we are able to auscultate the three lobes. It's an advantage of the lateral area we are auscultating. In left side, only two lobes is there. Then only the oblique fissure is start from second thoracic spine, imaginary line from second thoracic spine towards the sister rib, equally divided into two parts. Then upper segment is left upper lobe, lower is left lower lobe. Then very clear. This picture is very clear. Then you start to read just the stretches from above downwards. The look. Then very beginning, maybe we are not identifying this all these stretches. Then above downwards. Then soft tissue stretches, mainly a translucent area is visible in the center. Is the trachea, is the lung parenchyma, is the cardiac shield. The cardiac shield include the different chambers. Is an area of the right atrium, is an area of the ascending aorta, is an arch of aorta, is an aortic knuckle, is an area of the pulmonary trunk, is an area of the left atrium, is an area of the left ventricle. Then again, is a descent downward. The density we are identifying, then descending aorta is a descending aorta. Then well-defined cardiac shield. The hemi diaphragm we are identifying. The right hemi diaphragm is the left hemi diaphragm. Then from just below the left hemi diaphragm, the below is a diaphragm. Below that a translucent area is there. Is an indication of stomach. Is a stomach, area of stomach. Is the female X-ray. Then mammary shadow is there. The scapular markings, the listen is an overlap this lung field. Is a bad quality of this X-ray. Then here the little area is overlapping. Is a bad quality of this X-ray. Well centralized, equidistant in right and left side, equidistant. Above the clavicle, then apex of the lung. Okay, the fine vascular markings, this area of hilar lymph node, hilar area, hilar lymph node. Then suppose in primary complex include three important findings. One is hilar lymphadenopathy. Second one is caseous necrosis, and third one is bone foci. These are collectively called it as primary complex. Then one of the evidence we are visible in our X-ray, that is the hilar lymph node enlargement. Hilar lymph node enlargement we are expected in the fourth intercostal space. Then all the pictures are very clear. Pulmonary trunk. Then our respiratory system is an area of the hilar node. Then first condition. That discuss the sinusitis. The sinusitis and upper respiratory diseases. Then this and frontal sinus. Then area of the maxillary sinus. Then ethmoid and sphenoid sinus. In traditional X-rays, then normally, then for the study of the sinus, we are advised X-ray PNS, paranasal sinus. PNS include frontal and maxillary, ethmoid, and sphenoid. But in PNS X-rays, we are not visible ethmoid, and sphenoid. Only visible frontal and maxillary. For the study of ethmoid and sphenoid, need CT. Otherwise, we are not identify the ethmoid and sphenoid. The traditional X-ray, then X-ray PNS is sufficient for is an enough to work out frontal and as well as maxillary. Then sinusitis. The haziness over our affected area. The terminology we are used, then X-ray terminology we are used the haziness. Haziness over affected area. Suppose the sinus means we are expecting normal a translucent area. That means black in color. But the instead of the black color is replaced by white patch. That is, we are called it as haziness. The haziness is there. It's an indication of sinusitis. The look here is an area of the maxillary sinus. The area of maxillary sinus is an area of the maxillary sinus. But this much of area is haziness. We are looking this much of area. That means is the left-sided maxillary sinusitis. And three level of interpretation. First one is the any color change. That here the black color is replaced by white. In the terminology we are use this white is the haziness. It's the second level of interpretation. Then again correlated with the clinical symptom, this haziness and the pain over here plus pain over, then subjective and objective level finding is there. Then that means physical examination finding and as well as then subjective level symptom is there. We are diagnosed is sinusitis. These are the three level of interpretation. This X-ray is very clear. This first X-ray is well-defined border, well clear. A translucent area is we are seen in both sides. This is a normal maxillary sinus. But here in this X-ray, this side is an almost is a normal. Only we are seen black in color. But here they are seen the haziness. Almost area this black color is replaced by haziness. That is the haziness over this area is an indication of sinusitis. This X-ray is on right side almost is affected, right maxillary sinus, but in left side almost is a normal. This is an orbit, is an frontal sinus, is an area of frontal sinus, is an area of frontal sinus. In this case, the frontal sinus is normal. Then the CT, advantage of the CT, and CT is mainly useful for workout. Even we are suspected ethmoid sinus and the sphenoid sinus. Then look here is an ethmoid sinus, is an haziness over this area. We are comparing the right. This is the right side. Is a CT. Is the right side. Is the left side. We are comparing right and left. Here we are seeing the fluid level is an indication of haziness over this area. Is the left-sided ethmoid sinusitis. Then the picture is very clear. Next slide it shows and help for you. Look very clearly work out the ethmoid sinus. The normal morphology of ethmoid sinus. Then here the fluid collection is there. Is an indication of left ethmoid sinusitis. It's a left-sided ethmoid sinusitis. This ethmoid sinus is normal. This is an area of sphenoid. Is a maxillary sinus. It's a CT of a maxillary sinus. The maxillary sinus is inflamed. Then haziness plus and patchy opacity is there. Very thick fluid is there. Therefore, patchy opacity we are visible. But this one is a normal. This side is normal. This here the opacity is there. The haziness is there. This and sinusitis. Right side haziness is visible. Is an ethmoid sinusitis. haziness over affected sinus. This is haziness over affected sinus. It's a very clear picture. The ethmoid sinus, ethmoid sinusitis. It's an area of the frontal sinus. If the picture is clear, the haziness we are seeing over the frontal area, the frontal sinusitis. X-ray PNS. Our important medicine for the sinusitis, the inner head, forehead, bursting pain sinus, catarrh in frontal, antimonium cruda. Inner head, forehead pain, high voice over the left from metallica. I not read all the medicines and its indication. Then suppose then screenshot is you are needed just to take it. And otherwise the time is very short. We are not able to complete all that is the topic. The next condition is the pneumonia. The common condition, then inflammation of the interstitium, infection of the air spaces and the interstitium of the lung. Depending upon the number of distribution of the air spaces involved, it may be present as confluent parenchymal opacity or patchy opacity. Then that means, then suppose a particular lobe, different segments are there. May be affecting the particular segment, that time we are called it as segmental pneumonia. But maybe it's an affected the entire lobe, we are called it as lobar pneumonia. Maybe it's an affected the bronchus and its branches, the bronchopneumonia. The old term lobular, lobar or segmental. But nowadays, according to the etiology base, we are classifying the pneumonia, bacterial, viral, fungal. But older days, we are called it as then region wise, we are work out prospectively. Is an affecting the bronchus and its branches is the bronchopneumonia. Then affecting a particular lobe, we are called it as lobar pneumonia. Inside the lobe, the different segments are there. Then affected only a particular segment, that time we are called it as segmental pneumonia. Then listen, then already we are discussed where is the location. The 3 level of interpretation. First level of interpretation, then we are already lay out the X-ray PA view. We are read from above downwards. We are checking the qualities of the X-ray. After that, just you are work out this particular area. Normally we are expected black color. That black color is replaced by white color. In white color, we are called it as patchy opacity. The patchy opacity. The time a confusion is there, whether it is the lower lobe of the right side or middle lobe of the right side. Middle lobe of the right side. Then for that, you must advise lateral view. The lateral view advantage we are already discussed. Then lateral view, we are able to observe the 3 lobes. Therefore, suppose we are doubt we are erasing, we must advise right lateral view. The right lateral view that clearly able to differentiating is an affecting the middle lobe. Affecting the middle lobe. Then lower lobe is the normal translucent area. Then above, that upper lobe is normal. Therefore, in this manner, we are able to differentiate is the right middle lobe. This X-ray is very clear. There's so many findings are there. Test X-ray PA view, the structures we are seeing above downwards. Then almost all the qualities are maintained. X-rays exposed up to 10th rib. Then, but the certain areas we are marked. That is the color is changed. This segment is, this area is changed the color. Then here we are expected color is changed. Then again, this particular area also expected normal white and black color is changed. This is the first level of interpretation. Then second level of interpretation, The second level of interpretation, then here, then a halo white color, then inside a black color. A halo white color is an inside a black color. Then here also, very thick white color, then inside the white color, we are seeing a black color. This is an area of the black. But here, we are seeing a level, a water level. That is, we are called it as fluid level. Then above the fluid, we are seeing a translucent area. Translucent means black area. Then it is surrounded by, again, a white shadow. Okay. That means the first level of interpretation is over. Next time we are used here a very thick, homogeneous, dense opacity. Above the opacity, a level is a fluid level is there. Above that, a translucent area. Again, it's covered by a very thick, a white color. Is an again a dense opacity. And here a ring-like white shadow. Here also a ring-like white shadow. The next level of interpretation, a fluid level is there is an indication of abscess. Abscess is a very large abscess. You are assume that inside the abscess, that is after necrosis, the majority of lung parenchyma is damaged. Therefore, an empty space, therefore black color is there. Then just below that, the fluid, presence of the fluid. In abscess, one of the fate of an acute inflammation. You know, everybody know acute inflammation and its fates are one is abscess formation or it tends to chronic inflammation. Yes, this one is an abscess formation, but here what happened? Then later a chronic infection that healed by fibrosis. This ring-like white color is an indication of fibrosis. That means it's an old cavity. It's a new cavity, the formation of new cavity. The cavity presentation is an indication of pulmonary tuberculosis. In this manner, we are able to work out each and every X-ray. First, we should work out what is the layout of the X-ray, what is the normality endpoint. Just you check it. Then just you are work out the qualities of an X-ray. Then 3 level of interpretation. The first one is what is the normal color, what is the normal contrast we are expected in a particular structure. That contrast is changed, that points are we are noted. Then we are used and appropriate the terminology, radiological terminologies. And with the help of the terminologies, we are identifying the correlated with the subjective and objective level symptom. We are the final diagnosis. In this X-ray, there is a particular area is not the entire lobe is affected. Not entire lobe is affected. Only the particular area is affected. Is a segment of a particular lobe. Here we are expected right upper lobe. Inside the right upper lobe, only the minimal areas we are seeing patchy opacity. That is called it as segmental, homogeneous dense opacity. Is an indication of segmental. The segmental lobar pneumonia. This X-ray, where is the lesion? An area is an white patch is increased. Is then right upper lobe. Then suppose the right upper lobe or left upper lobe affection, just you remember, just you concentrated whether the person is under a chronic infection or not. Just you remember a chronic infection, tuberculosis. Is an lobar pneumonia. It's a case of right upper lobe pneumonia. You can identify. Then almost the area is an white contrast. Almost area of the left side is then left upper lobe, then left lower lobe. Then not only here affecting the lower lobe, the both lobes are affected. The left upper lobe and the left lower lobe. Then suppose again doubt is arise, just you advise left lateral view. Then this is an X-ray. At least we are our interpretation. This patient is we are admitted in emergency department because we are connected the different instruments. Their image is there. The look, the different instrument we are placed. Then almost areas that patchy opacity. Then almost areas that patchy opacity is an indication of respiratory failure. This is not an affected lobar pneumonia. The bronchus and its branches are affected. In children, the common pneumonia is bronchopneumonia. In adults, is a lobar pneumonia. In children, we are expected the lobar bronchopneumonia. But in treatment side, the management of the bronchopneumonia is very difficult. But it's an affecting the lobe, then for a particular period of time, the other lobes are functioning, then followed by the maintenance of the oxygen. But is an affecting the bronchus, then information inside the branches of the and its bronchus, what happened? The air is not reaching to the alveoli. Therefore, the bronchopneumonia is very dangerous than the lobar pneumonia. In children, the common is the bronchopneumonia. Reason I am treated in 2002 is an patchy appearance and right middle lobe. It's very clear. Within a few days, the treatment in this case is treated with the pulsatilla. Then here, just you here workout within the our curing time. The normal recovery period, everybody know. That means stage of congestion, stage of red hepatization, gray hepatization, and resolution happen within 14 to 16 days. But our result we are shown within 16 days never says an action of a homeopathy medicine. Therefore, this time we are remember that cure when the cure established, then our hearing says the 5 points. The duration of illness is decreased. The first one. The duration of illness. Suppose the 14 days the recovery, then always if our medicine is acting in the curative level, our the result we are expected within this recovery period. There is an advantage. It's in a case of bronchopneumonia. They are treated in 2006. Is again treated with, in my knowledge, antimonium tartaricum. And within few days, the result is there. Then another case of bronchopneumonia. The test is very clear within 21 to 25th itself. The child is normal. Within 4 days, the result is there. Almost the bronchus, the patchy opacity of the bronchus is disappeared. The case of another case. The case of right middle lobe pneumonia. The bronchopneumonia is in Master Surya, 1.5 years, then admitted in our IP. Yes. They are admitted in our IP. Then through their presentation, we are diagnosed the case. Then X-ray shows the bronchopneumonia, sign of bronchopneumonia, the drooping of eyelid, the severe weakness is there. There is no any other subjective level symptoms we are collected. The cough nature base, we are selected the medicine. Then prescribed antimonium tartaricum due to the drooping of eyelid, we are selected. Then other symptoms. Then objective level symptom base, we are selected antimonium tartaricum. It's mixed in 10 ml aquadista and 1 hourly 2 times. Medicine is prescribed, drowsiness, debility, cold set, and the child is always the desire for must sit up. The 2 drugs in my mind, one is the belladonna and second one is antimonium tartaricum. These are the objective level finding. The next day itself, next day within 24 hours, then rapid recompression of normal vigil. The child is absolutely normal. Then action of our antimonium tartaricum, the drooping is disappear. The generals are improved. The generals means not only appetite, thirst, elimination, etc. In addition to this, what are the uncommon peculiar characteristic symptoms? First year disappear, uncommon peculiar characteristic symptom. Within 24 hours, the child is better. And actually, this is a case from the allopathic science. Then drowsiness, this way we are prescribed the medicine. Another case of a bronchopneumonia and 5 years old female child, the brought to the OPD with her parents residing at Velarada having the complaints of fever 5 days, cough with the shortness of breath 2 days, nasal block and watery discharge in 7 days. The temperature at that time only 99.6 and SpO2 that is reduced 88%. The pulse rate is little very high. The respiratory rate is also very high. Then actually that time the patient is here need the supportive, then auxiliary measures, then oxygen, etc. But they are not given. Then auscultation shows the right-sided fine crepitation. Then you are admitted in an IPD 5/12/2019 and administered, and again in this case also an pneumonia tartaricum and a bronchopneumonia. Then very good result is there. Then inner chest lung pneumonia lobes, the oleum jacoris, then a wonderful medicine, then or just your mind, oleum jacoris. Then upper lobe pneumonia. Then chest lung pneumonia sided, left sided, lacusis and sanguinaria. Then right lung, the 3 drugs, chelidonium, lycopus and spiller for the pneumonia. The medicine acting on different lobes. The please take a screenshot. There's no enough time. Test and abscess. Abscess we are already discussed. Then X-ray. Then abscess. Then a fluid collection. Above the abscess, the fluid collection is there. Indication of abscess. The acute, we are acute fate of. Then a fate of an acute inflammation is an abscess formation. Okay, fluid level is there is an indication of an abscess. And in this X-ray, a large cavity. Okay, then the hypertranslucent area, plus then here the halo appearance indication of the fibrosis is an fluid, is an large cavity. The cavitation, one of the feature of primary complex. It's a primary complex. The classical X-ray evidence are hilar prominence, the gone foci, and caseous necrosis. We are already discussed. Sign of fibrosis. Sign of fibrosis. And ESR is rise, the lymphocytosis, manostasis help to establish the activity of the disease. Then a post-primary pulmonary tumor, then upper segment shows edgy opacity, the sign of fibrosis. And neuropathy, these are the common medicine in for the conception of the TB, the stage wise. The first stage, they recommended 2 medicine, cactus and tuberculin. First stage plus mucus expectoration, sternum match. The second stage, the stage of red hepatization. This one is stage of congestion. First stage, stage of congestion. Second stage, the Calicarb recommended. Then advanced stage, they recommended one of the drug, Trillium pendulum. Then suppose then you are able to individually diagnose the case, definitely that medicine you are prescribed. Suppose you are not collected the right picture from the patient, just you try with these medicines. The last stage, they are recommended. Then Dr. Herring is recommended. That is lobelia. In last stage, please offensive sputum, melandrium. The next, another condition, the common condition in our day-to-day practice is emphysema. Emphysema is an under COPD. Then emphysema means the dilatation and deterioration of the distal to the terminal bronchioles. Suppose you listen. Then look, then finding a bronchus, then divided into two, right and left principal bronchus, then again divided into different primary bronchioles. This one is secondary bronchioles. Primary bronchiole, secondary bronchioles. Again, secondary bronchioles is divided into tertiary bronchioles. Then tertiary bronchioles again divided into terminal bronchioles. Terminal bronchioles again divided into respiratory bronchioles. And finally, respiratory bronchioles alveoli. The emphysema means distal to the terminal bronchioles. Suppose this is a terminal bronchioles, we are divided into two. This is the distal part, this is the proximal part. Then distal to the terminal bronchioles, respiratory bronchioles, and this alveoli. All these parts, titration and dilatation is called emphysema. But above the terminal bronchioles, the proximal part of the terminal bronchioles, then tertiary bronchioles, secondary bronchioles, primary bronchioles, and principal bronchus. And its dilatation and titration is called it as bronchiectasis. It's a differentiating point of bronchiectasis and emphysema. Suppose emphysema is there, these are the classical X-ray evidence. The classical evidence are, one is the AD pattern. First one is AD pattern or IM pattern. And second one is absence of Hemi diaphragm. Then straightening of ribs, widening of ribs, hypertranslucent area. These are the classical features of radiological evidence of emphysema. The first one is we are discussing AD pattern and IM pattern. This particular X-ray, they are not visible the bronchovascular markings. Now listen, in this X-ray, this particular area, we are not visible bronchovascular markings. But below segment, distal segment, we are seeing bronchovascular markings. The fibrous root structures are visible. But here we are not visible. But in left side, almost all the areas we are visible bronchovascular markings. Almost all the areas visible. Then here we are discussing, try to convey with you what is AD pattern and IM pattern. AD pattern, otherwise called it as arterial deficiency. Arterial deficiency. The arterial deficiency, otherwise called it as polygemia. Polygemia. What is the reason for arterial deficiency? Suppose here the alveoli is over-dilated. Because emphysema means dilatation and deterioration of alveoli, respiratory bronchioles, and terminal bronchioles, distal part of the terminal bronchioles. That part here is a normal alveoli. The normal alveoli. All other segment is a normal alveoli. But what is AD pattern? Then due to the over-dilatation, in between the arteries and these branches, bronchovascular markings are there. Due to the pressure, we are not visible then these arterial marking and bronchovascular markings and bronchial marking. If the bronchovascular markings are absent, that is called it as arterial deficiency. That due to the pressure, compression, they are not visible bronchovascular markings. That is called it as arterial deficiency. Suppose one of the classical feature is arterial deficiency, absence of bronchovascular markings. Due to the absence of AD pattern, then test X-rays shows only hypertranslucency. Only we are seeing black color. But the normal simultaneously. Suppose this is an affected area, diseased area. Diseased area. What happened? Anything is? Shall I continue? Madam, anyone responded?
No, you can continue,
No,
doctor.
please continue. I request everyone to please mute themselves.
Sir, remaining
the
15
speaker will be
minutes. Okay, sir. Remaining 50 minutes.
Okay. Continue, sir.
Okay. This is an AD pattern due to arterial deficiency. Just please wait. Then here we are not able to see vascular markings. This area affected area. Diseased area. But what happened if this part is unaffected? What happened to the normal tissue? Normal tissue always producing inflammatory response. Due to inflammation, what happened? Then aggregation of reaching our neutrophil, our eosinophil, therefore, then vasodilatation. Due to vasodilatation, the markings are increased. That is called it as IM pattern, increased marking. When affected area shows AD pattern, unaffected area shows IM pattern, increased marking. The increased marking is an indication of inflammatory response. Due to inflammation, normal tissue always producing inflammatory response. One of the inflammatory response is vasodilatation. Then due to vasodilatation, our inflammatory cells are rushed in that place for the prevention of the enemy. Therefore, X-rays in emphysema, two classical finding is AD pattern and IM pattern. Then here, almost area is an IM pattern. Then look this picture, then almost area is AD pattern. Due to AD pattern, you are not visible the bronchovascular markings. You are not able to see the bronchovascular markings, only AD pattern, the hypertranslucency. And second point, then important point, how to check the Hemi diaphragm. And traditional X-ray, the please wait. Yes. How to check the Hemi diaphragm? Then for the calculation of the Hemi diaphragm, first you are identify right and left side costophrenic angle, and this one is the costophrenic angle and the cardiophrenic angle. Then again, an oblique line is drawn in between two these CP angles. And a line is maintained. Then oblique line. Then to identify the highest point of Hemi diaphragm. This is the highest point of Hemi diaphragm. Is the area of the highest point of the Hemi diaphragm. Then again, a perpendicular line towards this oblique line. Then here this distance 1 centimeter to 1.5 centimeter is a normal Hemi diaphragm. 1 centimeter to 1.5. But this distance is less. This distance is less. Suppose less than 1 centimeter, indication of absence of Hemi diaphragm. That means Hemi diaphragm is flattened. Suppose is greater than 1.5 centimeter, the Hemi diaphragm is prominent. Hemi diaphragm is prominent or Hemi diaphragm is absent, we are able to interpret it. For example, listen this X-ray. The Hemi diaphragm we are identifying this is a costophrenic angle and cardiophrenic angle. This distance is below 1 centimeter. That is absence of Hemi diaphragm. Absence of Hemi diaphragm is indication of flattening of That is called it as flattening of the Hemi diaphragm. Just a minute, I'll show you. Yes. The flattening of the Hemi diaphragm. This distance is less, very less. And what is the reason? Because here the alveoli is contained rich than our air. Then all the alveoli is dilated due to the pressure. Hemi diaphragm is pushed downwards. But what the time the Hemi diaphragm is prominent? Suppose our lung parenchyma is shrink or atrophied, the like athalatasis. What happened? Our Hemi diaphragm is prominent. That is, distance is more than 1.5 centimeter. In this manner, we are able to work out the Hemi diaphragm. Then hypertranslucency, absence of the Hemi diaphragm, widening of ribs, and due to the oocyte, the lungs are dilated, our heart becomes narrowed. Narrowing of the heart, another indication of emphysema. Tubular heart. These are the classical evidence of emphysema, COPD. Now listen, in this picture, this is an unaffected area, this is an affected area. This is a the hypertranslucency, that is only a segmental area, only we are seeing. Then arterial deficiency, that is this an emphysematous area, but almost other areas is normal. Then this is an X-ray, very useful for us to under this hypertranslucency. Then narrowing of our heart shadow, Hemi diaphragm is an absent. These are the classical features. The straightening of ribs, the widening of ribs, other classical features of emphysema. These are the other classical, these are another X-ray of emphysema. All these pictures are visible. Then bronchitis. Bronchonographically, bronchitis and its indication is the bronchovascular markings are prominent. The bronchovascular markings are prominent is the classical feature of bronchitis. But then suppose in clinical practice, the classical symptoms of chronic bronchitis there, you should advise an X-ray. X-ray shows bronchovascular markings are prominent. How do you check the bronchovascular markings are prominent? So just ask your patient, any prior X-ray is there? Any prior X-ray is there, just to compare with the previous X-ray and existing X-ray. That time only we are clearly differentiated the prominence of bronchovascular markings. I will show you. This one is the prior X-ray. The same patient, the prior X-ray, the bronchovascular markings are normal. But this time we are advised an X-ray, the bronchovascular markings are increased. Plus clinical signs and symptoms is there. We are able to declare is that chronic bronchitis. Chronic bronchitis under one of the condition under COPD. Then asthma. Asthma is characterized by widespread reversible narrowing of bronchial airway, changing rapidly in severity either spontaneously or within treatment. Bronchonographically, there is no evidence we are seeing in bronchial asthma. Only the bronchospasm is the pathology of bronchial asthma. But in repeated bronchospasm is there, is then followed by chance of bronchiectasis. The bronchiectasis is there bronchonographically. Then traditional X-rays, bronchiectasis, the bullae is visible. This bullae, we are misinterpreted the patchy opacity. Therefore, the final diagnosis of the bronchiectasis, we are need CT scan. There is a suspected case of bronchiectasis. Immediately, like our in sinusitis, our ethmoid and sphenoid sinusitis, in traditional X-rays, the PNS X-rays never given a guidance. For that, we are advised the CT. Likewise, here, they are suspected case of bronchiectasis, they are immediately advised CT scan. Then respiration asthma, these are the important medicines. Just you take a screenshot. Now listen, it's a bronchitis. The bronchitis here look like the patchy opacity. Here and here a patchy opacity. It's a misguiding. The like a segmental pneumonia, like that pictures are there. Actually, this is a bronchitis case. This is a bronchitic bulle. But we are for the confirmation, must we are advise CT scan. The CT scan, bronchitis means the dilatation and deterioration of primary, secondary, tertiary part of the bronchus. Dilatation and this deterioration is called it as bronchitis. So listen, is the primary bronchioles, is the secondary bronchioles, is the tertiary bronchioles. But the respiratory bronchioles and the distal to the terminal bronchioles are normal. Is not dilated. The here is not dilated. But the first parts are dilated. It's a classical feature of bronchitis. It's a patchy opacity. It is a bronchitis bulle. It's a classical feature of bronchitis, the CT. The first part of bronchus and its divisions are we are seeing the patchy opacity. Is a bronchitis. These are the common symptoms. The symptom wise we are repertorized. These are the group of medicines. The only common symptoms we are considered and repertorized: pulsatilla, calicarb, lycopodium, silicea, phosphorus, rionia, cossicum. These are the mainstream medicine for the bronchitis. It's a case of bronchitis asthma with the bronchitis. Then actually bronchitis in chronic, we are incurable in nature, but on case we are successfully, that in my practice, 3 or 4 cases have successfully managed the bronchitis case. This also shows the curing procedure. Then in this case, then bronchitis, we are trying with the pulsatilla. I am not going to the details of the case. Then this is CT scan. The report shows ground glass opacities and associated with resolving pneumonitis, then followed by the fibrotic changes with the traction bronchitis in right middle lobe. This case and successfully managed with the or pulsatilla. Then also very beginning, then spirometrical value shows obstructive abnormalities. Then obstructive and as well as restrictive lung diseases. That is then spirometrical values. Then FU1 values, FU1 and FU2 values are decreased. Therefore, average and obstruction and as well as a moderately severe restriction in that case, very beginning. Then after pulsatilla, then all the lab reporter shows that time that no obvious abnormality. There is no any evidence of bronchitis. The next time the spirometrical values are almost normal. There is no very baseline restriction and obstruction is there. Then after a period, in this case, they're developing atopic dermatitis. After that, compared with the last around 40 years, she is suffering from the bronchial asthma and the respiratory ailments. Almost we are disappeared. The patient is absolutely normal. It shows the cure. Is an interview with that particular patient. There is no enough time and not just you are missing. Chest and pleural effusion. Just only 5 minutes remaining. The last condition we are discussing the pleural effusion. Pleural effusion, everybody know fluid is accumulated in the lower, in between visceral and parietal pleura. Then for that, you are suspected case of pleural effusion. A little confusion is there from the consolidation. For the confusion, for the rectifying this confusion, just you advise right lateral decubitus posterior. That time we are already discussed the right lateral decubitus. That time the fluid is mobilized to the dependent part. Then very first, the lung parenchyma is not visible in this area. Then second X-ray, right lateral decubitus posterior, this lung parenchyma is visible. This is an indication of is not the inflammation of the parenchyma, that is the consolidation. Is an actually the fluid is accumulated in between visceral and parietal pleura. Then one more condition, athalatasis. Then athalatasis, that is a shrinkage. Then pulmonary edema. That is in pulmonary edema, that classically associated with the cardiac enlargement. this X-ray. Then very beginning I say is an area of aortic knuckle. The left atrium is large, and also the left ventricle also large. Then right atrium also large. Ascending aorta also large. That is called it as globular heart. It is called it as globular heart. The globular heart is a classical indication of congestive cardiac failure. In congestive cardiac failure, there are different types of cardiac failure is there. Right-sided failure and left-sided failure, forward failure and backward failure. In our forward and backward failure, that is the blood is pooling inside the viscera, internal vital organ, that can lead to right-sided heart failure. Right-sided heart failure. In right-sided heart failure is there is an precipitated, the evidence, the precipitated findings we are seen in our lungs, especially fluid accumulated inside the alveoli, that is the pulmonary edema. That is mist-like, it looks like mist-like patchy opacity. It's a classical feature of pulmonary edema. The other features are, that is curly B line and curly A line and C line. Out of these, curly B lines are very important. What is these different curly B, A, and C lines? The curly B line is indicated lymphatic drainage. The peripheral lymphatics, then inflammation is there, definitely lymphatic, simultaneously the lymphatic drainage. The peripheral lymphatics is indicated, a horizontal line-like structures is indication of curly B line. Curly B line always we are seen in the periphery of the lung, near to the costophrenic angle. Then suppose in our traditional exercise, when heart is large, then all of a sudden a clinician is look over, this is curly B line is present or not. Curly B line is present is indication of lymphatic drainage. The lymphatic drainage is there is an indication of pulmonary edema. Then curly C and A line is represent central lymphatic is not evidence in our traditional X-rays. Then now we are almost a portion of the respiratory diseases we are covered, remaining for 3 or 4 conditions. The time is very short. Therefore, once again, extend my sincere thanks to the organizers. Give me a topic regarding the basics of the chest X-ray interpretation. Thank you, one and all. Any doubt related to our discussed portion, please ask me. Thank you.
Yes, Dr. Ajayan. Okay, now it's the time for question answer section. If any doctors would like to ask any questions, kindly unmute. Dr. Ritu, they can unmute themselves now.
Yes, they can.
Or they can type in the chat box.
Yeah, I think there is
one question. One
there.
question Dr. Vanida has asked Dr. Ajayan.
Yes, sir. Yes,
Can you please throw some light on adenoids in X-ray?
Yes, and just sorry, the lateral view of the neck, we are visualize the adenoids. Lateral view of that extend the posture, is an helpful to work out the adenoids. It's not in the chest X-rays. In chest X-rays, we are not work out the adenoids. For the adenoids, we are advised that neck X-ray lateral view in extended posture.
Yes. Very good.
Okay.
Any other question?
Adenoids and associated with so many other features. The child at night only breathing through the mouth, the dryness of mouth, the child crying at night, all the days are crying at night. Then high arch palate. These are the other classical features of adenoid. In that case, I suggest to advise that neck X-ray lateral view is an enough for to work out the adenoids. Then adenoids is a compressed, that is an nasopharynx, we are visible. Is another portion, therefore is not included in this session.
I hope. Yes, yes. Of course, it's we are today. We have done with the text. Even you have covered some. I hope no more questions are there.
I don't think any more questions.
Now the time is also.
Dr. Santosh, your voice is breaking.
Yes, doctor, it's breaking.
Yeah, now it's okay.
Yeah, now can you hear me?
Yeah, I think Dr. Deepak has a question.
Yes, Dr. Deepak.
Hi, Doctor, very wonderful presentation, and I think easy to understood type of presentation by most of the doctors. I just have one question, since you have so much of experience with respiratory medicine and homeopathy. Now, when we see the lobal specific homeopathic medicines, like right upper lobe, chelidonium, or Merck in right lower lobe, how much show short results, you would say? What is the percentage of result when we select on specific lobal in specific medicines, lobe specific medicine?
Okay, sir. Then actually, then specific medicine means, and homeopathy specific medicine means, and according to our Lassen principle, according to the individuality only, we are able to select the medicine. But at the same time, then suppose in my practice in an emergency medicine department, we are developing the different protocols. Then suppose that a patient is an unconscious and then due to the lack of perfusion to the brain, and then all of a sudden maybe we are advised an exercise, then maybe then exercise and given a guidance for me. That ways only we are utilize all these things. Then our medicine selection is based on according to our Lassen principle. Then specific medicine means according to the right totality base we are prescribing medicine is the right one. But then so many times then the specific medicine then indication then related to a particular lobe, that time we are called it as is an uncommon peculiar symptom. In my knowledge, all the common symptoms are uncommon, all the uncommon symptoms are also common. Suppose that just in our face a discoloration, the same time another discoloration we are seen in the thumb, then the both are we are seen in a particular medicine. That time that two features, this discoloration we are considered as uncommon peculiar characteristic feature to that particular medicine. Then maybe isn't helpful. We are utilizing our day-to-day practice. That's all, sir.
What I have been doing in my practice is, suppose I see a confirmed finding based on auscultation of the lung. Let us say if left upper lobe, I clear-cut see crepitations, and the medicine on symptomatic indication is different. I try to add the specific lobe-related medicine along with it, and we get very good results with that.
Okay, sir. Okay, sir. Okay, sir. Thank you. Thank you.
Very good. Anyway, Dr. Ajay, excellent presentation. You have
Thank you,
taken
sir.
us to our college days as if we were in the classroom.
Sir,
Anyway,
one thing is also my failure, because we are and then actually it's a seminar. In seminar presentation is not like this. It's
No,
a
no,
classroom like this. That is my failure, sir. Therefore, and I know. Okay.
But it is not your failure. It is good for all of us. Because
Okay,
you have
thank you,
taken
sir.
us there, and it was an excellent presentation. You have covered all the topics, and we are very happy to be here along with us this time, and we would like to hear from you in the future also. Thank you. Thank you, Dr.
was
Ajay, for the wonderful presentation.
It's a compliment, sir, not a criticism.
Very good. Anyway, it's passed to Dr. Ritu for the final proceeding.
Yeah.
Thank you, Doctor.
Thank you. Thank you so much, Dr. Arjun. I think it was a wonderful lecture. And I thank all the participants also, all the doctors who took out their valuable time to be part of the talk today. With this, I think we'll wind up the session, and we would look forward to the next presentation, probably next year, third Wednesday of next month. Let us see what we come up with. And of course, next week we'll be having this case, not the case, but we will have the recording of Natrum muraticum, part 1 and part 2 both by Dr. Ihab and Dr. Santosh, followed by Dr. Deepak. So we look forward to that, and thank you all. Thanks once again for being part of today's program. Thank you.
Thank you.
Thank
Thanks.
One and all.
Thank you, Dr.
Thank you,
Dr.
everybody.